It's really fantastic to see so many people here. We were a bit nervous at the beginning that we wouldn't get enough people registering, and then it came to the point where we were having to start to turn people away, so that's a really positive thing. It's coming slowly. I was just really going to, I just have a very short talk, and I was really going to talk about what children's palliative care is and what kind of services we have in Ireland and the challenges that we face in Ireland, because there's been a huge positive drive and really goodwill towards children's palliative care in Ireland, and so much has happened over a short period of time. Sheila Reap-Reynolds from the Health Service Executive is going to talk briefly at the end around different policy documents over the last few years and how the National Development Committee is progressing children's palliative care in Ireland on foot of that. So I was really just going to talk, as I said in brief, around children's palliative care and what that means if you're a child with a life-limiting condition in Ireland at the moment. I suppose the first thing I wanted to say is, what is paediatric palliative care or children's palliative care? And I don't know if the next slide will come up very well, but I don't know if you can read the title on the buggy there. It's a buggy from an airport, but it says Terminal Express. And I think sometimes working in children's palliative care and in adult palliative care, people view part of our work as only around end-of-life care or terminal care, which is care in the last few hours or days of life. That's a part of what we do, but it's actually a small part of what we do. It's not exclusively what we do. And the UK organisation, the Association for Children with Life-Limiting or Terminal Conditions and their families, provided a definition a number of years ago, which most people use as almost the gold standard of definition alongside the WHO definition. But if you look at the definition, it's a really broad one showing that part of our role is the holistic care of a child with a life-limiting condition, embracing all aspects of their life and supporting them and their families right through their illness, helping provide respite, helping manage symptoms, and helping their family through after the death and into the bereavement process. And so one of my big take-home messages for people in the audience who may not be aware of children's palliative care, and I'm aware that there's a huge proportion of the audience who work closely in paediatrics and in children's palliative care. It's really just trying to educate that palliative care, it does not mean that it's one or the other. The child can have ongoing active treatment, and we would be involved with children who have repeated visits to the intensive care unit. It's a parallel process with active care. It does not mean no care. It may mean that the goals of care may change, and every parent and every family have hopes and dreams for their child, and just because their child has a life-limiting condition does not mean that their hopes and dreams, that they don't have hopes and dreams. It just may mean that their hopes and dreams may be a little bit different to what they were before their child was diagnosed with their illness. And it's really a principles that should be integrated into all care, particularly areas where children may not survive treatment or may have conditions that means they're unlikely to survive to adulthood. And it's really important that we try and progress and integrate children's palliative care into units such as oncology, intensive care units, neonatal intensive care units, obstetric units, transplantation units. And it's really difficult because a lot of our role is around educating staff around our how we can help. And it's, we often, even people that are working in paediatrics still have a misunderstanding as to what we do. Just recently, we had a little girl who has a very profound life-limiting condition. There was a lot of discussion around whether she should have a tracheostomy. There was many detailed discussions around the ethics and the benefits and burdens of having a tracheostomy. And eventually, in conjunction with the family, a decision was made to have a tracheostomy and have long-term ventilation. And a couple of days later, when we went to visit her in the intensive care unit, the staff there were, well, why are you visiting? She's no longer palliative. So there was this feeling that because an intervention was done, we no longer had a role to play, even though this little girl still has a life-limiting condition and still has a long road ahead. So it's really around educating people as to what we can do to help staff and children and families. The thing is, palliative care can happen anywhere. It's not a physical building. It's only a number of months ago that I was asked to provide an answer to the Irish Parliament around whether we should build a perinatal hospice, because there was a misunderstanding as to the need for having a physical hospice building for families to deliver babies that have life-limiting conditions. So there's this feeling that there has to be a physical place, but palliative care can happen anywhere, and all of us are capable of providing palliative care in some form or other. So it can happen in a neonatal unit, it can happen in a paediatric unit, it can happen in a purpose-built paediatric hospice building, and it can happen in a home. The bottom right-hand picture is actually a home of a little boy that we cared for a number of years ago. It actually almost looks like a hospital room, but it's somebody's home, and families become amazing in how they care for their children and how they manage to keep them at home despite huge medical and nursing needs. So again, it's around the holistic care of the child regardless of where they are. So what kind of children do we see? I suppose we will see any child where the feeling is that they may not live until adulthood. And sometimes I say to teams, if they're wondering about whether palliative care could help, I ask, would you be surprised if the child were to die before they reached adulthood? And if the answer is no, then perhaps a palliative care ethos should be instigated. And particularly if you ask a team or the primary paediatrician, would you be surprised if this child were to die within the next year? If they say no, well then really they should be considering having our support. There's lots of reasons that we get referrals. The main one usually is symptom management, particularly pain, and it's true to say that no parent can see their child suffer in any way, shape or form, and no family or parent is able to address all the other holistic, social, spiritual, psychological side of caring for their child, or the child themselves cannot cope with any of those other aspects if they're suffering and in pain. So our biggest role is around symptom management, but also around helping facilitate that transition between hospital and home, or hospital and hospice and home, and making that transition as smooth as possible. We also are involved for end-of-life care, particularly in the hospital setting, and also helping if there's difficult ethical dilemmas or decisions around benefits and burdens of treatment, and also bereavement support. We would really dearly love to be able to provide much more bereavement support, but our staff is so stretched and small that it's become quite impossible to provide the bereavement support that we would like. So what kind of services do we have in Ireland at the moment? I thought this was a cool picture of building a bridge. It's really all about teamwork. As I said, there is tremendous goodwill and tremendous positivity towards children's palliative care in Ireland. We have amazing teams of nurses and doctors and healthcare assistants and healthcare workers of all types, and volunteers working in the voluntary sector and also in the statutory sector. And it's all around working together and trying to bridge and make transitions and care as smooth as possible. The reality is, if you're a child at home or in hospital with a life-limiting condition, you can have as many as this many teams involved in your care, which can be quite complex and can take a lot of coordination and teamwork. And it just shows you how many organisations there are and how many people there are out there that are desperately trying to help these families. And part of the role of the National Development Committee is to try and pull all of these teams together, and we've representation from pretty much all of these teams on the National Development Committee to try and ensure that children's palliative care develops in Ireland with everybody taking an equal part in caring for these children. The specialist team of which I am part is based in Our Lady's Children's Hospital Crumlin. I also have a small remit to the CUAM, as Sharon eloquently put it, which is difficult to fulfill because of my workload, but I try my best to meet women and parents antenatally if they have a life-limiting diagnosis in their pregnancy, and also to help postnatally with any baby in the neonatal unit. The team was established in 2001 when Maeve, who's in the audience here, my brilliant co-worker, and Marie, my amazing co-worker as well, were asked by the oncology department to start visiting the oncology department in Crumlin. They're adult palliative medicine physicians, so they started coming over for 2 sessions a week, and it gradually, rapidly became evident that there was way more need than just the oncology department. We're a consult service. We provide consult from all teams and specialties within the hospital. I'm the only full-time consultant. I'm 5 years in post as of a couple of weeks' time. There's one part-time consultant, 2 sessions a week, which is job shared between Maeve and Marie. They bring with them an adult palliative care SPR in training and an SHO who's on the GP training scheme with them for those sessions. And we have 3 CNSs who all work half-time, so we have 1.5 amazingly hard-working and tolerant of me and the rest of us CNSs. We work very closely with the child's team, particularly their primary paediatrician, whether it be within Crumlin or throughout the country, but also the GP, the public health nurse, the local community adult palliative care team, and the children's outreach nurse, which are new posts over the last few years. As I said, we take referrals from all teams, and part of our role is to provide phone support and advice for teams across the country. So we may get calls from a team in Donegal or a team down in Valentia Island or anywhere in the country, and we support the GP, the local paediatrician, and the adult palliative care teams. As I said, we're additional support for the outreach nurses, and we're also involved in education, and we also are members of different committees, the National Development Committee and their subcommittees, the Palliative Care, Clinical Care Programme and Clinical Advisory Group. I'm the Paediatric rep on that, and I'm also the Palliative Care rep on the Paediatric Clinical Care Programme, CAG, and we're also on the Irish Association of Palliative Care Board and Special Interest Group. So as you can see, it's very busy working life. We rely very heavily in Ireland because of our geography and our population distribution. We rely heavily on the amazing adult palliative care teams throughout the country who do an amazing job in helping us support children for end of life to try and keep them in their communities, whether it be at home or in their local hospital. And they provide the adult palliative care expertise and would work very closely with the local GP and with the local paediatrician, and also link in with ourselves. Teams vary throughout the country. Some have inpatient hospice units, some are based purely in acute hospitals, and some are in the community only. Most of them are consultant-led, some are led by CNSs, and they usually have access to multidisciplinary teams such as social work, psychology, OT, physio, and again they liaise closely. If you're looking for information as to what local palliative care team you might need to have involved if you have a child at end of life, the Irish Association of Palliative Care has a superb link on their website with all the contact details of the palliative care teams, and the Health Service Executive on their website has the application form which can be easily downloaded. It's a generic application form for all teams. In the last few years, one of the major developments has been the children's outreach nurse for children with life-limiting conditions. These are paediatric nurses, which are I compare them a little bit to the community paediatric nurses in the UK, except that these nurses only work with children who have a life-limiting condition, so they don't link in the community with the diabetics or the asthmatics. They're supported locally. They're embedded in their local paediatric unit and have a large geographical area to cover, which is a huge challenge for them. And they're supported locally by their own director of nursing, their lead paediatrician, who is a champion for their role, but they also really tie in with the child's local paediatrician, and they get support from myself. But part of their role is to link with all the community services, statutory and voluntary. And this is just, it didn't come out very well, but you can just see there's 8 outreach nurses at the moment, and there are some more hopefully coming on stream this year. Sheila will probably mention those in her talk. Ideally, my dream would be to have 1 per county, so we'll try and lobby for that, because I think geographically it's impossible. If you're, I'm just giving Colette, sorry, I know you're in the audience, but Colette has this massive chunk here to cover, which, you know, if you've got a child each side of that area, you're driving for hours just to see one or 2 children. And their aim was to try and smooth the transition between hospital, home and hospice if necessary. Then really must mention the Jack and Jill Children's Foundation, which has been really working hard in Ireland since 1997. It was founded by Jonathan Irwin and his wife Marianne O'Brien of Lily O'Brien's Chocolates after the tragic death of their son at 22 months back in the early 90s. They work with children up until the age of 4 years, children with profound intellectual and physical disability, but will also help care for children at end of life up to the age of 4, regardless of their background diagnosis. So even if they're cancer or non-intellectual disability. They have 12 liaison nurses spread geographically throughout the country, and they help provide financial support for direct in-house respite and nursing care for the child, and they also support the family in a similar way to the children's outreach nurse, and their website is there. We've been very lucky over the last few years. Laura Lynn Children's Hospice Foundation was created by the amazing Jane and Brendan McKenna, again after the tragic death of their only 2 children, their daughter Laura, aged 4, from a congenital cardiac condition, and their daughter Lynn, aged 15, from a cancer. The hospice was built on the grounds of Children's Sunshine Home, which was is a disability service centre in Leopardstown, and it opened in 2011. And it's a really good resource for us. This is a picture of Laura Lynn. I can't really go without mentioning the Irish Cancer Society, and really this is where all your proceeds on the Daffodil Day goes. But the Irish Cancer Society will provide funding and towards nurses, or directly provide nurses for end-of-life nursing at night for anybody regardless of their age, from baby to 199. They'll provide up to 10 nights from 11 p.m. to 7 a.m. And their last figures that I could find was from 2013, 1,868 families availed of the service, which was 7,770 nights in total, and that's their website. So that's another amazing charity. So I suppose it's all around teamwork and everybody working together to try and do the best we can for these children and their families who find themselves in this very sad situation. There are many challenges. I'll just briefly go into the challenges. Again, it was around the knowledge among the multidisciplinary team around our role, which can sometimes lead to delays in referral because people feel that, you know, this isn't really palliative care. I know when they were doing the respite needs assessment a number of years ago, when they approached some of the units that provide services for children with severe neurological impairment, the services were couldn't understand why anybody with a palliative care background was talking to them, because they said, we don't do palliative care. But then on further questioning, they did have children with profound needs and children who died. So I think there was that mismatch of understanding as to what children's palliative care is. This uncertainty can lead to team and parental anxiety. So we often have a team almost apologising or tiptoeing around the family around referring, and you can see that on the family's faces when we go in, and there's a huge anxiety as soon as you go in the door, and often kind of other family members are hushed away or the child is pushed out of the room. And it can also mean that there's urgent last-minute referrals, particularly at end of life within the hospital, which perpetuates the feeling then that we're only involved in in end-of-life care because they're the kids that we're getting to see. So again, it's trying to increase our role in palliative care, our role in the ICUs and in the units where children have a life-threatening or a life-limiting illness. We have a huge issue, and I think this is internationally, sourcing competent and suitably trained doctors, nurses and allied health professionals, and trying to ensure continuity of care. Children are becoming more complex in all ways over the last number of years. Medical technology has advanced greatly, but this also means that children are living longer with their condition and are going home with way more complex machinery, such as ventilation machinery, feeding tubes. A lot of our children now have surgical jejunostomy feeding tubes. They may have BiPAP or CPAP ventilators. So this means that there is much more nursing or allied health professional input and causes more anxiety in the community around these children coming home. But it also means that there is higher anxiety among the GP and the primary paediatrician, because the child often has a huge relationship with the tertiary hospital and isn't coming back to their community as much. So when we're trying to keep children at home, particularly at end of life, this can cause great anxiety. And also it means that it's very difficult to predict trajectory. Children often end up in ICU and do very well and come out of ICU. So families are, well, let's go to ICU again because the last time John got out of ICU. So it means that it's more difficult to predict and to counsel families. And it can be very confusing for families. You saw all the organisations, statutory and voluntary, that are going into the house, and this can be really confusing. Who do we call in a crisis? It may end up that the family call everybody, and you have lots of people doing the same job in the background. One of the big issues is lack of support. We provide telephone advice 24/7, but it's a grace and favour basis. It's not an official on-call rota. And what we really need is 24/7 access for families for support and advice and symptom management. And inequity. I mean, my dream would be that if you live right next door to Crumlin Hospital, or if you live on Valentia Island in Kerry, better not say Cork because I'll get killed, in Kerry, that you would have access to the same treatment. And again, limited budgets. So just very briefly, and this is my last slide, I think just since I came on board in 2011, our referrals have really shot up. They've more than doubled, which means that also a number of deaths that we're involved with has more than doubled. And this is a huge impact on our team because our team hasn't really expanded. And I feel that often that we're firefighting and trying to just lurch from one crisis to the next. So what we really need is more staff. But for the children, all they need is their family. They need love. They need to be comfortable. And hopefully having us involved and helping support the teams can do that. So thank you.